Thank you and good morning. Thank you to the program committee for giving me this chance. I don't have any disclosures. So from an EVT decision making, what do we know? Well, we know now that time is really irrelevant, right? So you need favorable imaging, a clot you can grab, and a corresponding clinical deficit. And if you think about what's involved in our fund of knowledge, right? So as with any other procedure or surgery, the person doing the procedure needs to understand what the appropriate patient selection is. You need to understand what the optimal medical management before, during, and after any procedure. So whether you're a cardiologist that's going to do thrombectomy or whoever you are, you need to know this stuff. Just a quick background for those of you who haven't visited lovely Providence. This is where our comprehensive stroke center is. These are the 15 primary stroke centers that are closest to us. Access is not a problem. This is 20 miles, so pretty much everybody in our region lives within very close proximity to the comprehensive stroke center. Now, as I talk about this paradigm of transfer managed by neurointerventionalists, I just have one caveat that's going to be important. We do not provide teleneurology or telestroke for any of these PSCs. They have third-party vendors that provide their services, and that will be important. So we know that access is important, and we've developed a protocol that focuses on the neurointerventionalist being the one that triages. And so what happens is the patient goes to a primary stroke center, and we've gone to and educated all of these primary stroke centers that the minute they hit the door and you think they're likely to be an LVO, call us. So we have suggested that they call us before any imaging on all of the LAMS 4 and 5 patients. We then have one of 3 attending neurointerventionalists who fields these calls 24/7, 365, and we work the PSC through the entire transfer process. The first thing we ask them is, how are you going to get them out of there? And especially in some of these places that are 45 minutes away, how are you going to do that? And there's a couple of different options. A lot of the EMS agencies are actually willing to stay after the patient gets TPA, put them back on the same truck. This is a convenient way. We call this drip and go as opposed to drip and ship. And the alternate is we can mobilize our transport team. So if the PSC does not have a transport team readily available or it's going to take them a while, we'll send our team out there. And the idea there is waste gas, not brain. We have gotten every one of these PSCs to do the CTA there. And we've educated them, do the CT and the CTA, do it on the first trip to the scanner, don't do the creatinine. And we use a secure cloud-based product called LifeImage, which then transmits the imaging directly to the neurointerventionalist, and we can look at this. So why do the CTA at the PSC? And I think that this is important. It really reduces the burden of unnecessary transfers. So if you look at this data from Rush, 67% of patients did not have a large vessel occlusion when they're transferred based on clinical scales alone. So, and it's also conceivable that they may get a bill for transport, especially if you're going to use air. That's a substantial bill for transport, and it turns out the patient had a seizure. They had conversion disorder, whatever it is. We looked at how good are we at detecting CTA and comparing the ELVO detection on our smartphones using the LifeImage app. It turns out we didn't miss any. And so what we did then is we said, all right, how good can we get in terms of our times to treatment? And so what we saw is that when someone fully executes the protocol, they call us early, they do the imaging right away, we can get onset to reperfusion times that are just over 3 hours. And the vast majority of this is by reduction in door-in, door-out times, by having the neurointerventionalist literally walk the primary stroke center through this entire process. When we get to the CSC, we have a couple of other important steps, right? So the neurointerventionalist is on the phone. They've heard about the patient. They know what the medical issues with the patient are. We've seen all of the imaging. We've seen the arch. We've seen where the clot is. So we don't repeat the imaging. We go directly to the angio suite. We do not stop in the ED. That's a time sink. That's 30 minutes of your life you'll never get back if you stop in the ED. So just go directly. And our median door to puncture for transfers is about 15 minutes, right? So they literally come in the door. Are they breathing? Fine. Go. Put them on the table. But what ultimately a transfer thrombectomy is a transfer for a procedure, right? It's a minimally invasive procedure. So shouldn't the proceduralist be the one that's taking the lead in triaging this transfer? And so why is this better, right? So what's going on at the primary stroke center? There's an ED doc, and at the neurointerventionalist is here at the CSC. Here's your friendly vascular neurologist, always glad to help. Actually, that's your friendly vascular neurologist, always glad to help. And so what's going on in the mind, right? So the ED doc is thinking, should I transfer for thrombectomy and should I give IV TPA? And the person who's receiving, on our end, we're thinking of lots of different things. Which hospital is it? How far away are they? What's their age? What's their functional status? What does the imaging look like? Am I going to have to stent? Is this a tandem? All the usual stuff that goes on. So it's complex math, as my partner Ryan McTaggart likes to say. So why is this better? So this is a direct conversation. The ED doc is asking, should I transfer this patient for a procedure that you do? And so she says, yeah, 50-year-old right-sided weakness. And say, yep, I've seen the images. There's a left M1 occlusion. I'm going to accept the patient. We're going to transfer directly to the angio suite. Because I've gone through that in my mind. What's the checklist, right? The clot I can grab, there's favorable imaging, corresponding deficit. Do I know if they score 4 or 3 on the NIH stroke scale for arm weakness? No. Does it matter? No. And then we send out the page. So then the neurointerventionalist sends out the page that says, you know, Mr. Smith has a left M1 occlusion. They're going directly to the IR suite. At this point, the vascular neurology team is notified. Now, when we first started this paradigm, we got criticism because people said, well, what about IV TPA? You know, shouldn't you help with the IV TPA decision making? And yeah, I mean, they're wondering, should we give IV TPA? But this is actually a really easy decision. Yes, of course, if they meet your local guidelines, give TPA. And what we found is that ED docs at primary stroke centers, when they have a CTA that shows an occlusion, they're way more willing to give IV TPA to those patients than without that. So it really gives them an extra level of confidence. We've even had this happen where they say, but they're on warfarin, the INR is pending, and what do? The transport team's here. And we say, real simple. Put them in the truck. Here's my cell phone. Call me when you get the INR back, and we'll make a TPA decision. And again, our region, most of these places are 30 minutes or less away. And so, you know, I think as with any procedure or surgery, the physician doing this is responsible for the outcomes. And one of the other things that this does is it eliminates all of the blah, blah, blah and the back and forth between vascular neurology and neurointerventional. So if I call Andre and say, hey, there's a 55-year-old, so stroke scale 17, it's a left M1, and what's he going to say? Why are you wasting time calling me at 3 a.m.? Go get the clot out, right? This is an obvious case. Or I could call him at 3 a.m. and say, you know, there's this lovely 98-year-old. They're really highly functional, but they're demented in a nursing home with aspects of 3, and they're an hour away. And he's going to say, why are you calling me? You know, what are we trying to do here, right? But instead, you can just focus the conversations on the interesting cases, right? So, for example, this is a case where we do talk about it before triaging as yes or no. I'd say, you know, it's an M1 occlusion, but the stroke scale's 3, and I don't think it's ICAD. What do you want to do? And so this is where the neurologist will, well, that's interesting. Okay, what should we do? Let's talk about this with the family and the patient about it. And I think that, you know, if you really look at it, it comes down to you got your greens, which are the easy ones, you've got the easy no's, and then the thinking cases. And if you decide as a larger group, and my friend and colleague Brad Thompson, who's the head of our neuro ICU, likes to say, you know, decide as a group on Wednesday afternoon and a full cup of coffee what your easy yeses and easy no's are, then you eliminate all of this unnecessary back and forth. So at the end, I think that the neurointerventionalist can and should triage LVO transfers. We understand who should and shouldn't be treated. We're responsible for doing the case. If something goes wrong, if we perforate the MCA, that's on us, right? It makes less phone calls for obvious cases and make it like any other surgical procedure. But at the end of the day, you need to find out what works for your system. And the one thing that I think everybody can agree on is just treat patients quickly. And I do think at the end of the day, we can all get along here. So, thank you.
Thank you, Mahesh. Well, I think we're going to find a friendly stroke neurologist to discuss the other perspective. Andrea Alexandrov, chair of neurology and expert in many things LVO, will be talking about who should triage LVL stroke neurologists.
Man, if you want to take that call, you must be desperate. I would just summarize it that way. And you must be coming from a center that we agreed long time ago, a minimum 25 TPAs a year and minimum 15 thrombectomies a year, right? So you're willing to take a call and to talk to everyone. So welcome to Memphis. Walking in Memphis, 700 TPAs, and up to 400 thrombectomies last year, average number of calls a day, 50. You want to take some of it off me? Be my guest. All right, so if you look at your consecutive patients and consecutive call, the number of mechanical thrombectomies or LVOs, max 30%. I like that slide that you showed that if you base on CTA, most do not have occlusions. So most conversations that we have are not about thrombectomy. So we need to offer access to stroke expertise to all patients, not just super select group. Because if you only focus your discussions with ED physicians on abnormal CTAs, guess what? They're not going to call you on normal CTAs. They're not going to call on CTAs that have unobvious branch occlusions or partially occlusive thrombi that radiologists miss. They're going to call you less, and we will be treating less patients. So that's a simple message from this slide. The other thing, I call it stop poaching code stroke. Equally wrong would be call strokes CVAs. You know what CVA stand for? Confused vascular assessment. So if you have confused vascular assessment and someone in all of that teases out, okay, here is ELVO, okay, let's call neurointerventionist. Oh, here is ICH, let's call neurocritical care. Subarachnoid hemorrhage, let's call neurosurgery directly. So who is triaging all of that for you if not vascular neurologist? You need to ask that question. Who originates these calls in your system? So stick to code stroke. So going back to mantra of CVA, obviously, TPA should not be given for all CVAs, right? We have another mantra, MRI for UTI. So TPA for CVA, MRI for UTI. But if you and our friend Tudor take over the selection, then will be DSA for USA, right? So we cannot do that. All right. So finally, what are the reasons why vascular neurologists should take call? Again, most strokes do not have LVOs, still need treatment, and the treatment may not be just TPA, there may be some other things we do. Management before thrombectomy is important, blood pressure. So you're going to have time, you're going to drop your case, you're going to take that mask off of that little cartoon and spend time talking 2 or 3 times to the same emergency physician who's going to call, oh, labetalol is not working. Okay, anyway. Stroke mimics, another important thing. I want to hear the story. I want to triage this for you, and I want to rule those out. Early management of intracranial bleeding. That's another frontier that we are exploring. How are you going to do clinical trials for patients that do not qualify for mechanical thrombectomy, okay, or drip and ship clinical trials? And we are all in this together to minimize transfers, of course. So a few last messages. Interventionist, of course, the goal is to score the goal, to put balls in a basket. So we all know these guys, right? But you know that Ronaldo did not win any championship because he was always viewed as Ronaldo plus 10, right? Yeah. Only until he changed attitude towards Portuguese national team and valued his deliver and assist team, then they won the Euro Cup. All right, so first goal, deliver and assist, be the team player for vascular neurologist. And second, defend the outcome. You mentioned that complication and outcome is on you. No, it's also on us. Because right now, I think equally important as selection to thrombectomy is what we do after thrombectomy, particularly blood pressure and things we do with either stroke units or ICU. So again, using STEAM analogy. So code stroke team sport, totally agree. Attack wills you games, defense wills you titles, right? And what a talk will go in the United States without Yogi Bear. The game ain't over until it's over, right? So the game doesn't begin and end in the angio suite. I rest my case. Thank you.